exciting things that have been going on in the field of diabetes over the last 5 years or so. And those changes have been driven by research funded by the NIH, by industry, by foundations. And here at the University of Minnesota, we've been at the center of a lot of that research. So to tell you about it today, we have Dr. Brandon Nathan, Associate Professor in Pediatric Endocrinology. I think you all know Brandon well. You may not know as well Dr. Jennifer McVean because she's only been here for a couple of years. She's an Assistant Professor in Pediatric Endocrinology. So I'll turn grand rounds over to the two of them.
All right, thank you. Okay, so here are our disclosures. I speak for Medtronic Diabetes, and Dr. Nathan has received research support from Novo Nordisk and Medtronic. We're also going to be discussing some off-label medications as well as a non-FDA approved artificial pancreas device. So our objectives today are to help you understand that type 1 diabetes can be predicted, and it actually happens in predictable stages. We're going to talk about what the type 1 diabetes exchange is and how it has helped us more about type 1 diabetes in the US. And finally, we're going to end up with talking about the most recent therapy that is really changing how we manage type 1 diabetes. So type 1 diabetes occurs in about 1.25 million Americans. It happens when it's an autoimmune disease where the body attacks the cells in the pancreas that make insulin. And usually when about 85 to 90% of those cells have been destroyed, people present with the typical symptoms of drinking a lot, peeing a lot, and losing weight. Most people are diagnosed with type 1 diabetes as children. However, increasingly we're seeing that adults are also diagnosed with type 1. And actually, because of the advent of insulin about 100 years ago, 84% of people living with type 1 these days are actually adults. You can see that the healthcare cost to the US, and that's an annual figure, is $14 billion. So it really is quite a burden of disease. So because of the burden of type 1 diabetes, it led some of my predecessors to ask a couple of very important questions a few years back. First of all, can type 1 diabetes be predicted? And if it can be predicted, can it be prevented? And so, and I'm glad that they asked those questions because my path to standing here today started 30 years ago last month when I was diagnosed with type 1 diabetes. And these kids who are smiling and sometimes well-behaved and sometimes not well-behaved are my kids. And so my interest in prevention of type 1 diabetes really is because of them. So what was founded was something called Type 1 Diabetes TrialNet, and it is an international study. There are about 20 centers in the US, and the goal of TrialNet is ultimately to prevent type 1 diabetes from occurring, and in the interim to also preserve beta cell function in those who have been diagnosed with type 1 diabetes. This is funded by the National Institutes of Health as well as by JDRF. Dr. Moran is the principal investigator here at the University of Minnesota, which is one of about 15 to 20 coordinating centers in this country. And I'm going to take a brief minute here for a little advocacy. What I've realized in the last couple of years is we can only take care of one patient at a time, but we can advocate for hundreds, if not thousands, if not tens of thousands of people at a time. And the TrialNet is funded out of something called the Special Diabetes Program, which is a $150 million per year NIH, which gets refunded every 2 years. Unfortunately, the funding for the Special Diabetes Program ran out, as a number of many other programs did, the end of September of last year. I'm very happy to report that just yesterday, the House actually passed the Special Diabetes Program funding. And for those of you that I reached out to and asked you to send an email or call your representative, thank you. I'm going to turn it around and ask you to send an email or call your senator because they will be voting on that as early as today. Very easy. If you Google JDRF, Juvenile Diabetes Research Foundation, Renew SDP will pop up. Very easy to send a quick email. So, if type 1 diabetes can be predicted, what we've learned from TrialNet is that it can, where should we look? Well, the place that we should look is relatives of people with type 1. So in the general population, the risk is about 1 in 300. You can see the increasing frequency of type 1 diabetes in relatives of people with type 1. It's interesting that there's a discrepancy between if your mother has type 1 and your father has type 1. We don't really understand why that is. You can see that siblings are more likely to get type 1, and identical twins are extremely likely to get type 1. However, the concordance isn't 100%, so there certainly is something to play there besides genetics. So it turns out that type 1 diabetes can, in fact, be predicted with a simple blood draw. TrialNet is funded to look for type 1 diabetes in relatives of type 1. However, clinically, you could also predict type 1 diabetes with the same blood draw. So the eligibility requirements of this study are that if you're between the ages of 1 and 20 and you have any relative with type 1, or the ages of 1 and 45 and you have a first-degree relative with type 1, you qualify for this study. And really what the study does is it looks for the antibodies, the autoantibodies that are present at type 1 diagnosis and are present for months to years prior to that diagnosis. Now, we don't know exactly when the antibodies appear, and so hence for those under 18, if antibodies are negative, they can be rescreened annually until they are 18. So screening for the autoantibodies is free to relatives of people with type 1. And if antibodies are positive, and we'll go into that a little bit more next, the next step is if the people are interested to enroll in our prevention trials, because ultimately that is our goal, is to prevent type 1 diabetes, to find the people out there that are going to develop it and to hopefully help prevent or stop beta cell destruction. So after TrialNet's been going on now for 15 to 20 years, and after this amount of time, what's happened is we realized that type 1 diabetes actually develops in predictable stages. So the initial screen for TrialNet has autoantibodies that it looks for. It's the GAD antibody, glutamic acid decarboxylase, the IA2 antibody, which is a tyrosine phosphorylase, or an insulin autoantibody. And it turns out that if you have 2 of those positive, you are going to develop type 1 clinically. So when we look at these stages, this is something you may not have seen before, but in the last couple years, in the research arena, and I think it's moving forward somewhat into the clinical arena, although not quite as quickly, we've now called type 1 diabetes stage 1 if you have 2 autoantibodies positive, but you still have normal glucose tolerance. Stage 2 is you have 2 autoantibodies positive, but abnormal glucose tolerance. None of these people have symptoms yet. In stage 3 type 1 diabetes is what we thought of in the past as when you present to your pediatrician with the typical symptoms, drinking more frequently, urinating frequently, and losing weight. So type 1 diabetes progresses in stages. And so when we look at this ribbon moving down, at each step, there are fewer and fewer people that are affected. So people with type 1 diabetes are born with a genetic risk. And if you have a family member with type 1, your risk of developing type 1 is 15 times higher. But not everyone that has a genetic risk goes on to develop type 1. So the next step is immune activation, where the body attacks the cells in the pancreas that make insulin. And not everyone that has immune activation goes on to the next step, which is an immune response, where you develop a single antibody. Now, not everyone that develops a single autoantibody goes on to develop clinically a clinical diagnosis of type 1. But once you move down a little bit further, once you have 2 autoantibodies, that is now considered to be stage 1 type 1 diabetes, and you now have type 1 diabetes. It doesn't require insulin yet, but it will. Stage 2 type 1 diabetes is you now have abnormal blood sugar on a glucose tolerance test. And stage 3 is what we have thought of in the past as this is the clinical disease. So what we're looking at here is a Kaplan-Meier curve, and we're taking a look at how long it takes someone with 2 autoantibodies to develop type 1. And what you can see is the younger you are when you develop the autoantibodies, the quicker it is that you will develop a clinical diagnosis of type 1. So the black line, which you can see at 10 years, it's nearly 100%. Children who are under 5 with 2 autoantibodies positive develop type 1 quite quickly. Whereas those who are over 20 when they develop their antibodies, it takes longer. But the longer that this study has continued, and we have data that goes out 15 years and nearly 20 years now, nearly everyone, especially under the age of 20, within that 20 years, develops type 1. So some of you might be asking, why would we want to screen for a disease that we currently can't prevent? So a couple reasons. First of all, with all of the advances that we have made in type 1 diabetes in the last 30 years, we still have not been able to decrease the percentage of people, the percentage of children that present with diabetic ketoacidosis at their initial presentation with type 1 diabetes. 35% is staggering. Diabetic ketoacidosis is a life-threatening emergency, and those who are enrolled in TrialNet, only 5% develop ketoacidosis at their initial presentation. So that is extremely clinically significant. Secondly, if you know that that you have type 1 and you're going to need insulin at some point, if we can preserve beta cells for you and we can delay you needing to start insulin for a year or 5 years or 10 years, that is very clinically significant. We also know that people that have even a small amount of beta cell function left have a significantly decreased risk of low blood sugars, their diabetes is easier to manage, and they have fewer complications. And finally, it moves our field forward in understanding how is it that diabetes progresses from developing autoantibodies to the clinical disease requiring insulin. So I want to take a minute here and try, if I can, to help you understand a little bit better the burden of having type 1 diabetes. I read an article a couple years ago that it was an invisible disease, and I thought to myself, what do you mean it's an invisible disease? You see people giving injections, you see people checking blood sugar, you see insulin pumps. However, I think what you don't see is the millions and millions and millions of decisions that are made on a minute-to-minute basis that people with type 1 diabetes and their family members have to do all the time. Whether it's going to something as simple as going to a birthday party, eating lunch at school, sports, it really is quite a burden. And I threw that card up there for those of you that follow hockey. This is not our patient, so there's no HIPAA here. But Riley Tufte was Mr. Hockey 2 years ago, which is a huge honor in the state of Minnesota. He has type 1 diabetes. He was drafted by the Dallas Stars, and he is now in his second year at the University of Minnesota Duluth. So to be a player in the NHL takes obviously an unbelievable amount of effort and dedication, and I can tell you he has put in 10 times more than anyone else. And so it's really that burden of disease that has sort of shifted what TrialNet is doing and kind of shaped what TrialNet is doing in using disease-modifying therapy. And I have to admit we're a little bit late to the party on that. Most other specialties have started using these drugs, but we're finally there. I was happy to hear Dr. Binstad's talk a couple weeks ago and learn that tocilizumab, the C is soft, not hard, because we have a new onset study with that, and I'm not sure that any of us actually know how to pronounce it. But what's really exciting is all three of these drugs that are listed have actually been found in new onset patients to stop the decline in beta cells for up to a year. So the typical presentation of someone with type 1 is they present when 85 to 90% of their cells have been destroyed. And unfortunately, the process of disease over the next 6 to 12 to 18 months, the rest of the cells are destroyed. But what these drugs have been able to do is to actually stop that destruction for up to a year. Now, unfortunately, it wasn't sustained. And I think what we've realized is that the cure for type 1 diabetes is not going to be one thing. It's going to be a combination of therapies put together, and it's helping us shape the future trials that we're doing. And I'm going to hand it over to Dr. Nathan.
Thanks, Jen. Good morning, everyone. Thank you for coming. I'm going to switch gears a little bit here and move to a different trial network that we've been a part of, lucky enough to be a part of, called the Type 1 Diabetes Exchange. So the exchange was really founded back in 2011, and the idea behind the exchange was that we need to understand what's happening in the United States with type 1 diabetes. This is an area that we've actually been behind our European counterparts who have had national registries for individuals with type 1 diabetes and have learned a lot from disease in their country, how it's being managed, what types of therapies people are using, what works best for them. So the exchange was really founded in this manner. It was run by or funded by a charitable, amazing grant from the Leona Helmsley Charitable Trust, and it has continued to be in existence over the past 6 years. It really takes a four-pronged approach to answering some of those questions that I outlined and when I first started speaking. Those four prongs are through a clinical trial network, which has been a really powerful network that has been unbelievably collaborative, and I'll talk to you a little bit about some of the studies that have come out of the network. And then through the clinic registry. So this is the program that we actually were able to enroll for people with type 1 diabetes into the registry. We've enrolled over 26,000 individuals of all varying ages, duration of diabetes, and different ethnic backgrounds. The third arm is glue.org. So glue.org is an online community. It's a website that people with type 1 diabetes can connect, and I'll show you an example of that in a second. And lastly, the biobank, which is a repository for individuals in the registry to store samples and learn from some of the studies that we're doing, go back and do some further investigations on samples there. So the mission of the Type 1 Exchange is a better understanding of type 1 diabetes, improving the care and lives of people with type 1 diabetes, and accelerating the search for new treatments and technologies. And I'll go through some of those in a second. So this is glue.org. This is the website that people can connect to. And again, its primary goal is to generate new research and perform an ability to allow people to connect with each other, a community that people can embrace. What glue.org does is sends out queries or questions for people to answer. So we've learned a lot about how people are feeling about their disease, how they're managing their disease at home, what their interactions with their healthcare providers are like. So it's really been a wealth of incredible information for us, and it's a great way for people to connect to each other. So you can see down there the numbers that we've got: over 20,000 community users, over 150,000 comments. So it's really been an active part of the exchange. So here's just to give you an idea about the clinical trial centers and networks throughout the United States. We're really equally distributed across the country. The majority, about 2/3 of these sites are in academic health centers. Another third are in community centers. So we've got a little bit of both academic and also community practices. And there's also one HMO as part of the network. This will give you just some idea about the characteristics of the individuals that are part of the registry here. So age at diagnosis. And what you can see here is that about a little over half of the individuals that were enrolled were diagnosed in childhood, as you would expect, but it may be surprising for some of you that a substantial number of adults were diagnosed with type 1 diabetes. So I think in the lay population or in the community, in the general public, a lot of people don't think of type 1 diabetes occurring in adults. And in fact, it does. And you can see the numbers there that were diagnosed at significantly older ages than what historically we've thought of as juvenile onset diabetes, all right? So that's why one of the reasons that term has gone away. And the next slide tells you about how long some of these individuals have had type 1 diabetes for. So the majority, or about half of the individuals, have been diagnosed for under 10 years, but we've got a substantial number of people that have had disease for over 10 years, and you can see even several thousands that have been 20 years plus. And this really gave us a really robust data source and wealth of information that we could perform some of these other studies to understand how is disease different in these individuals, what's going on in those individuals who have had diabetes for a much longer period of time than some of the individuals that have been diagnosed for a younger period of time. Idea about the racial backdrop: about 80% of the individuals were Caucasian and about 20% from different ethnic backgrounds. The second most was in the Latino population, and then in the Black population too. And some of the other minorities were perhaps underrepresented, but not necessarily for what we see in the general population for prevalence of disease. So we do have some ethnic background. We would like to be a little bit more, but we do have a good representation from ethnic groups. But one of the themes I wanted to really impress upon you today was about how clinical trial networks can be very powerful. So like Jen was talking about, Type 1 Diabetes TrialNet, another extremely powerful clinical trial network. The exchange has been just as powerful. So since its inception in 2011, there have been a total of 54 published manuscripts from various ways that the exchange has been able to generate new information. And I wanted to just highlight a couple of those studies for you. I'm not going to go into too many details or go over all 54 studies that have been published, but I do want to give you some of the most relevant and I think meaningful new information that the exchange has been able to glean since onset. So one way that we've been able to publish is through the registry. And as an example of that, this is the C-peptide study, which I'll tell you a little bit more about in a second. So the C-peptide study was really to investigate, do individuals with type 1 diabetes continue to make insulin after diagnosis or not? And if so, what does that mean for type 1 diabetes in general? How does that change the way that we're thinking about disease? So I'll go over a little bit more in detail with that for you in a second. We've been able to do a number of intervention trials using the clinical trial network, and we were fortunate enough to be part of a couple of those studies. The first was whether or not metformin actually changed the course of diabetes or improved glycemic control in overweight or obese adolescents with type 1 diabetes, which is a growing problem. This is an area that lots of people had used metformin, but there really wasn't good data on it, very small case reports. So we made a new trial that was a clamp study and really investigated whether or not insulin could change whether metformin could change how much insulin they were using and whether or not it changed A1C outcomes. Been able to bring new products to the market. This was a study using intranasal glucagon. All right, so right now, people with type 1 diabetes, if they need rescue from a hypoglycemic emergency, they have to take intramuscular glucagon shot, which expires in a year and causes a number of side effects. So this was a way that we could look at a new product, a new delivery system. We performed clamp studies, hypoglycemic clamp studies in both children and in adults, and we're able to demonstrate that the intranasal glucagon was just as efficacious as intramuscular glucagon. And so very soon we're hoping to see that intranasal glucagon is going to be something that people can utilize. It's much easier to use, it's simpler, and it's just as effective. So that hopefully will be out able to be used clinically in a very short period. And lastly, we've had a number of international collaborations now that we've had the exchange in place for several years. So as I mentioned before, many other studies, particularly in Europe, have been way ahead of us on this and have generated a lot of data. So we've had collaborations with different countries such as Germany, Finland, some of the other Scandinavian countries, looking at how are patients being managed in one country versus the other. And this is the role that the exchange has really played here. And frankly has highlighted the fact that we are behind and we're not doing as good of a job as some of the other countries. So for the last little part of my talk here before I turn it back over to Jen, I'm going to just outline a few of the really, I think, important and exciting pieces of data that have come from some of the registry studies. So the first is a follow-up from that C-peptide study that I showed you before. When individuals join the type 1 diabetes exchange, they fill out a fairly extensive survey asking them various questions, characteristics about their disease. There's also a non-fasting blood sample that's done. And one of the first studies we did was to look at, do individuals have evidence for endogenous insulin production? So C-peptide is the marker that we use for endogenous insulin production. And we looked at whether or not people have that in different ages. So what this graph shows you here is detectable C-peptide levels there on the y-axis, and then on the x-axis is how long they've had diabetes for the duration of disease. And then the red and blue bars show you individuals that were diagnosed in childhood versus individuals that were diagnosed in adulthood. So you can see that for the first 3 to 5 years or so, that there's a substantial percentage of people who were brought into the exchange or enrolled in exchange that are still making insulin on their own. This is not necessarily new information. Other studies have shown that you continue to make insulin for 1 to 3 years, but the number of patients that were still C-peptide positive was quite high. As you extend out further away from diagnosis, not surprisingly, your ability to make insulin goes down, but it doesn't go away completely. So the take-home points here are that people, even 40 years out from diagnosis, somewhere between about 10% or so of those individuals will continue to make some amount of insulin. And the fact that there is a really substantial or significant dichotomy between whether you were diagnosed in childhood or in adulthood. And that had a pretty significant impact on whether you were making insulin or not. And you can see that the differences between the two bars. Why is this so important? This comes back to what Jen was talking about before. A lot of the new onset studies were trying to preserve beta cell function and allow them to continue to produce insulin. This reduces burden of disease, reduces hypoglycemia rates, lowers A1C values, and this has been demonstrated from older studies in the diabetes care and complications trial as long as 30 years ago. So type 1 diabetes is a very heterogeneous disease, and we need to understand better about why this occurs. Okay, this is the other one that's really, really important, I think, that's come from the exchange. So this really tells us about how we're doing in the country and in managing patients with disease. So I have up there that, where our goal A1C levels are for pediatrics, and then where our goal levels for adults are, 7.5% or lower and 7% or lower, respectively. So these are mean A1Cs at their most recent A1Cs for individuals in the exchange, and you can see this really big spike there between about 10 and about 20 years of age. This is the mean hemoglobin A1C here is about 9%. So 30 years ago in the DCCT trial, the mean A1C in 13 to 17-year-olds was about 9.5%. Is it lower? Yes. Is it a lot lower? No. We have lots of better ways of managing diabetes now. We have better monitoring systems. We have better ways of delivering insulin. We have insulin analogs. But we really haven't changed care in these patients. So this really shows us that this is a huge opportunity to improve care, not only in this adolescent and young adult population, but even when you look down to the adults greater than the age of 30, which is where you really see that cutoff and this line come in towards their A1C, they're still above their goal range. And that goal range is there because it is the level that is correlated with the lowest risk of micro and macrovascular complications. And we still have work to do, even in the adult population, of bringing those mean A1C levels down. So if you look just strictly at targets and how are we doing meeting targets, the two bars there are when people were first enrolled and then the most current data. We're not doing very well. Only about a quarter of patients on the high side are meeting goal, and that's mainly in the adult population. We're doing much less than that in the pediatric population. Moreover, over the last 5 years, it hasn't improved at all. So we need to continue modifying what we're doing. We need to continue coming up with new ways of managing patients and helping them reach some of these hemoglobin A1C and glycemic goals. How about amongst different ethnic backgrounds? Well, in the pediatric population, we've got a significant increase in hemoglobin A1C in the Black American children that are part of the exchange as compared to white and Caucasian. Importantly, this doesn't matter. This difference exists or persists whether you look at individuals using multiple injections or who are on insulin pump therapy. And this difference is more than what would be suggested even from known A1C differences between different ethnic backgrounds. We know Black individuals tend to have slightly higher A1Cs, but this difference is a lot more than that. So this is another opportunity. We have to do a better job and determine why children with type 1 diabetes who are Black are having worse glycemic control than other children. So some of the characteristics of people who are successful really came out in the exchange. This is one of the studies, and I use this in clinic all the time. And this really is just a correlation between glycemic control and monitoring or blood glucose testing. So the more testing that you do, the lower your A1C is. And that's true across different age ranges. And the more testing that you do, the better your A1C is. So this is a characteristic of people who are successful with their diabetes management, and that's just monitoring, which is easier said than done sometimes. But the more that you monitor, the better glycemic control that you have. So just as a quick backdrop, the DCCT trial, which I mentioned before, which is really the pivotal trial performed over 30 years ago, brought us to the point where we are now, where we're much more intensive with diabetes management. We have very specific A1C goals to reduce complications. From that trial, we knew that if you pushed your A1C down using an intensive insulin therapy, your risk of complications were less, but your rates of hypoglycemia and severe hypoglycemia went up dramatically. Well, the exchange has taught us that that is not the case anymore. And in fact, people with lower hemoglobin A1Cs down there on the x-axis, so less than 7.5, 8%, their rates of severe hypoglycemic episodes were the same or lower than individuals who had higher hemoglobin A1C levels. And that tells us a little bit about some of the ways that we can deliver insulin now. The insulin analogs are better. There's lower risk of hypoglycemia. But we're still not making A1C targets as well as we can. We should be, because the rates of hypoglycemia are not increased in individuals that have lower A1C values. Last two slides kind of bring it back to the last part of the talk, where Jen is going to talk a little bit more about some of the technological advances in management. But I just wanted to give you a little glimpse that in the exchange, individuals that are using insulin pumps have lower A1Cs. So this corroborates some of the other data and studies that have been done recently, that if you're using an insulin pump, your glycemic control is better. And there's a number of reasons for that, which I won't get into, and Jen will probably talk a little bit about in the last part of the talk. But no matter what age range you're at, if you're using a pump, your control is better. And although many people were not using continuous glucose monitors, and I'll back up for 1 second just to say that a continuous glucose monitor is an alternative way to monitor your glucose levels. So rather than checking your glucose off of your finger stick and checking a blood glucose, the continuous glucose monitor measures interstitial glucose levels, which is a surrogate of blood glucose, on a continual basis. So you get constant feedback every few minutes about changes that are happening in your blood glucose. These systems have been around for about the past 10 years, but have really been gaining steam as the accuracy and ease of use has really improved over the last 5 years or so. So if you're wearing a CGM in the exchange, you can see your A1C is also much lower than if you're not. So embracing this technology, we think, is growing, and we think is going to continue improving care delivery. Which brings us to the last part of the talk, and Jen's going to come back and talk a little bit about hybrid closed-loop systems.
All right, thank you. All right, so some of you see up there, maybe 30 years ago, you remember regular and NPH insulin, 2 shots a day. If there are any med students or residents who probably don't know what I'm talking about, which is actually good, because that means we've made progress. The insulin pump at the bottom, those really came out after about 2000, and they just have short-acting insulin in them, and so they deliver a little bit in the background all the time, and then you push the buttons to give bigger amounts when you're going to eat, or if blood sugar is high, to bring it back down. And then it's been the first commercially available system for continuous glucose monitoring came out in November 2006, and this really has been very exciting. So you basically, every 5 minutes, you it beams over to a pump, or you have a handheld device that tells you what your interstitial glucose value is. So really, we have made a lot of advancements over the last 20, 30 years. Okay, so we're in the home stretch. So I want everyone to take a minute and close your eyes and think of a really peaceful night of sleep that you had. So maybe it was after a really long call stretch. Maybe it was the first night your baby or puppy slept through the night. Okay, so imagine that night. Okay, so open your eyes and just think about how peaceful and relaxed that you feel. So I will tell you, if you have type 1 diabetes, or you are a parent of a child with type 1 diabetes, you have never had a peaceful night of sleep. Never. Why? Because every night before you or your child goes to bed, you have 100 things running through your head as to how you can make sure that you or your child is going to wake up in the morning. And that is really scary. So what things are going through your head? Do I need to increase their insulin because they ate pizza? Do I need to decrease it because they had activity? My continuous glucose monitor has 2 down arrows. It has 2 up arrows. When did I last change the pump site? Did they actually go out after when I told them to come in and not run around anymore? A million different things, right? And so despite all the wonderful advances that we have made, we still are not there yet. And so a few years back, there were some really smart and motivated people in the type 1 community who said, you know what? We have pumps. We have continuous glucose monitors. Why don't we just engineer a program so that we can make the pump deliver insulin based on what the blood glucose value is? And yes, at the same time, there are a lot of different commercial entities who are working on the same thing. But this group of people, understandably, felt like things were moving along too slowly. As wonderful as the FDA is, sometimes things don't get to us as quickly as we would like them to get to us. So what they did was, and here as we talk about a non-FDA approved system, where people took different pump parts and continuous glucose monitoring parts and kind of hacked into them, came up with a program, and there are thousands of users of these systems. And you have to buy the devices online and make your own system, but the computer program and all that, that's free. Anybody can have that. And there's an amazing network of people who are constantly troubleshooting this online and helping each other out. And if you think about it for a minute, if everyone could think of whatever your specialty is, whether you're a general pediatrician or specialist, think of some kind of disease that you take care of where we haven't yet, there's a lot of room for improvement, right? There's still a great burden of disease. So imagine if then your patients decided like they didn't want this chemo protocol, so somehow they got a hold of these other drugs and they made their own. Or, think of that is what this is. And so it really, it's really, I think, it's been a good thing because it's pushed the FDA to realize, like, people are going to do this. And the other piece of it is, as physicians, what I realized, I came across the first patient with one of these a few months ago, very sweet, very well-educated parents, and I'll tell you, this system works, okay? But we've all sometimes seen things in medicine that we've never seen before, right? So what do? I mean, I finished my fellowship 10 years ago, so I'm not straight out of the gates, right? Well, you read the literature, right? Or you talk to somebody who has more experience than you do. Well, what if there's nothing in the literature? And what if there really aren't any pediatric endocrinologists or adult for that matter that really have much more experience than you do? And so fortunately, the Juvenile Diabetes Research Foundation has realized that people are doing this, and we want to streamline this and make this safe and also educate people. I want to learn. I want to know how to take care of patients with whatever kind of devices that come in. But so I'll tell you, this thing is amazing. There are thousands of people on it. I don't think there will probably it's not for everyone. It works amazingly, but there is some work you have to do. But it really, I think, has pushed us in a good way to like, wow, we need to get this done. So fortunately, there was a commercial system that was approved on September 28th of 2016. You might wonder, like, why do I know the date? It turned out it was actually the day of my 40th birthday. So it was the best birthday present I ever got. Of course, I had to wait about 9 months after it was approved to get one, but so what it is, it's called a hybrid closed loop system. And let me explain that technology first. So the ultimate goal of any of these systems is to be completely closed, meaning it works like the pancreas. If you eat something, if you eat more, it puts out more insulin. If you're exercising, it puts out less. So this is hybrid. So this system targets the blood glucose value to 120. So if blood glucose is going up, it gives you more insulin. If it's going down, it gives you less insulin. However, the reason it's called hybrid is that you still have to tell it what you're going to eat. And the way we do that is by counting carbohydrates. So you enter in the number of grams of carbohydrate you're going to eat, and it gives you an amount of insulin because of that, based on that. So what it includes is an insulin pump. It includes the hybrid closed loop algorithm, a sensor and a transmitter, which are sensing the interstitial fluid, and then a blood glucose meter. So twice a day you do need to calibrate it, do a finger stick, make sure that the sensor is accurate. So there was a pivotal trial that was published in 2016 that led to the approval of this system. There were 124 patients in it, and they went down to age 14. The hemoglobin A1C, this was a safety study. So their outcomes were really how many people got ketoacidosis or severe hypoglycemia, but it also did show quite an improvement in hemoglobin A1C. So at baseline, the mean hemoglobin A1C of this group was 7.4, and at the end of the study, it was 6.9. No severe hypoglycemia and no diabetic ketoacidosis. So not only was it very safe, but it improved results. And some of you might have just, having listened to Dr. Nathan's talk, that, wow, like the data he was telling me about the average A1C being 9 is different when you're saying about the average A1C being 7.4, which is true. So I'll tell you, only 124 people got to be in this study, and people were lined up to be in this study. So I will say that the people that were in this study were those who were very well connected and able to get into it. That being said, after this company had their first 10,000 patients on the system commercially, they crunched the data, and it was actually nearly identical to their pivotal trial. So despite the fact that I would argue that this was probably not completely representative of the average person with type 1, it did perform that way once it was released commercially. So I know this is busy, but my point behind it is the black line, the dotted black line, is average blood glucose. And you can see the average blood glucose is fairly near 120. Yes, there's peaks and valleys, but the system really works. And if you look at the nighttime between midnight, 6 and 7 a.m., certainly that's the easiest time for the system because there aren't as many variables, but that is a pretty flat line. And this is not someone who was recently diagnosed that might have residual insulin production. This is someone who's had diabetes for a long time. So we're getting close to the end, and what I hope that I've showed you from the hybrid closed loop therapy, whether it's somebody who's using the non-FDA approved system or the one that's FDA approved, is that it really has decreased the burden of disease. And I will tell you, the only reason I know people with diabetes and their parents don't have peaceful nights of sleep is because 29 years, 5 months, and 1 day into my journey with type 1 diabetes, I finally had a peaceful night of sleep. And that was the day I started the closed loop system last summer. And so I feel that type 1 diabetes is a burden. It's like carrying a huge boulder up a hill at all times. And with the hybrid closed loop therapy, I feel like now it's a backpack. It's not gone. There are still a lot of things that you have to do, but fortunately these technologies have really made type 1 diabetes a lot more manageable. So in summary, type 1 diabetes is a progressive disease. We can predict it, and it has specific stages that we can use to help with our research studies to ultimately prevent it from occurring. So progress has been made in preserving beta cell function in new onset patients, but unfortunately it's not sustained, and so we're still looking for new therapies. Care of patients in the United States has also improved, but unfortunately we have a lot of work left to do, especially with African American patients. Newer technologies really does decrease the burden of disease and improve disease management. And hybrid closed loop therapy really it's a life changer and a game changer. It significantly decreases the burden of disease. Mitigating hypoglycemia, I think, is the biggest benefit of it. And so I want to end here. And this is Dr. Banting, who discovered insulin in 1921. And insulin is not a cure for diabetes, it's a treatment. And despite all of the advances that we have made in the last 100 years, we are still treating type 1 diabetes by replacing insulin. And I really believe that the pathway to a cure is in prevention, because if you can prevent type 1 diabetes, then within a couple of generations, you have cured it. And this is where I am going to ask for your help. We need your help. And when I say we need your help, I'm going to put on two different hats. So first of all, as a pediatrician and a pediatric endocrinologist and as a clinical researcher, we need to find those people that are going to develop type 1 diabetes, that have stage 1 type 1 diabetes. They have 2 autoantibodies. They're out there. We need to find them. You all come across them every day. If you are a general pediatrician and you have a patient who comes in and the child has a father with type 1 diabetes, all those children qualify for TrialNet. If you are a gastroenterologist and you have a patient with Crohn's disease and the dad has type 1, those kids qualify for TrialNet. As pediatric endocrinologists, we're pretty good at enrolling siblings of children with type 1 because we see them in our clinic. But there is a huge population of people that we do not see. So if you come across people, whether it's at work or in the rest of your life that have type 1 diabetes, please remember TrialNet. Please tell them it's easy to go online. They can do it all online. I don't know if you guys saw the footballs. I have more footballs. I wear these bracelets everywhere and give them out to anyone I can that could be qualified for the study. So please come after and get a football and get some bracelets. But secondly, and more importantly, I'm going to put my other hat on, which is one of the 1.25 million people in this country that have type 1 diabetes. We need your help. We need your help to end this. Thank you. Yeah, I guess we could take some questions.
I have a question about the antibody titers in stage 1 and stage 2. Do the titers predict the time to progression to stage 3? Do they go up between stage 1 and stage 2? My second question is, does modifying the Ig concentration with either plasmapheresis or IVIG delay progression to stage 3?
So as far as the antibodies, the titers, I don't believe that those are predictive of that. And some of these questions, I'm going to look at Dr. Moran to make sure that because she's been doing this a lot longer than I have. But I don't think that we don't look at the specific titers.
Yeah, it's more number of antibodies than titers. Titers wax and wane and aren't really predictable. And I have never heard of anyone using plasmapheresis to remove the antibodies.
And in fact, I'll just add to it that, we think that likely the antibodies are more of a marker of disease progression and the immunomodulatory or the immune response and the inflammatory response than perhaps pathologic in the disease process, so that plasmapheresis and those types of therapies may not really be helpful in the disease versus really modifying how the immune system is functioning.
Great talk, thank you. Question about this population of people, kids and adults who have impaired glucose tolerance, so this pre-diabetic group, which it seems like it's a lot of them. What is the current evidence with using metformin or other agents to kind of either delay or prevent kind of then the onset of true diabetes?
It's a great question. So I think that what you're probably referring to are the kids who are at risk for going on to develop type 2 diabetes, which is a little bit different pathophysiology, although there's some overlap between the two groups. So I think what Dr. McVean was talking about and what we do in the TrialNet study is to identify an even higher risk individual for progression to clinical disease. So once they have an autoantibody response, we know they have their immune system activated. As they progress through different stages, one of those stages, that stage 2, is when they actually start losing the ability to handle a glucose load. So that's where that impaired glucose tolerance comes from for individuals who are at risk for type 1 diabetes. The question of whether metformin is effective, which I know is a much bigger, can be a bigger issue because there's more patients out there who are obese and have risk factors for type 2 diabetes, is still at large, I'd say. And there's evidence from the initial DPT that metformin is at least somewhat helpful in preventing the progression to type 2 diabetes in adults and in young adults. Whether or not all these children and which children should be placed on metformin, should it be those who have a hemoglobin A1C of 5.9% or 5.8% or 6.4%, we don't know. The best therapy for those individuals remains weight loss and lifestyle modification. So in general, my practice is to not treat most of them, except in the ones that are at the highest risk, strong family history, maybe have impaired glucose tolerance on an OGTT. So I think there's a select group, but I wouldn't paint a broad brush on those kids.
Well, thank you for a real inspiring presentation. My question is about the closed loop system. It seems like this can really be a game changer for patients with diabetes. And you mentioned the safety study, which had 124 patients in it. And I think most would say that safety studies require thousands of patients. And what do you think of that? And are there ongoing trials to really show that it is safe?
That's a great question. So there are a lot of ongoing trials, and I think that while that was one study of that system, the pieces of that system, there have been many studies that have built up to that. So and that's back to what I was saying about the push for things to get approved, because people are going to do it anyway. And so I obviously wasn't a part of those conversations, but the FDA did require the company that makes that product to do 1,000-person post-marketing study, which is actually the biggest study that company has ever done. So that study is currently underway, and it's also underway in children who are younger than 14 as well. So on the doctor side of me, I'm 124 patients seems like not that many. On the other side, who wants access to the technology, I'm thankful it was approved. But yes, there are ongoing studies. Thank you.
And just as a follow-up, I think there is still quite a bit more we're going to learn about how patients and utilize this technology. And as Jen mentioned, the initial trial was really on a very motivated, well-controlled population to begin with. So the application of this technology to some of our adolescent patients, and we have some of them who have not done well historically and put them on the system, there's things we're still learning about. How do we implement that, and how do we help them use the technology best? So I think we're still learning. Okay, thanks very much.
Thanks.
You have been disconnected from the meeting.